Welcome to Wellness Week. My name is Gideon Orbach. I practice chiropractic here at the World of Wellness. I hold the distinction of being a doctor of chiropractic and a primary spinal practitioner, which I'll tell you a little bit more about in a moment. I've been here. I've been here at this group. I practiced on the South Side when we were in that building. I moved with Dr. Weiner to this building in October of 2008. So this year we're coming up on a big anniversary. Um, I've been here obviously since Dr. Weiner passed, and now we're the World of Wellness, but we're essentially the same people doing expanded versions of all the same things and taking care of our patients in the same way we've always have in the past and taking care of our clientele as best as we can and certainly carrying on the appropriate legacy. So, anyhow, as I mentioned, I'm a primary spinal practitioner, which is a certification program through the University of Pittsburgh's School of Physical Therapy. Now, for those of you that don't know me, I absolutely bleed blue and gold. Hail to Pitt on all things. I went to Pitt as an undergrad, and when I had the chance to do a program through the Pitt Physical Therapy Department, it was the first program of its kind in the country where chiropractors and physical therapists were put in the same classroom, where we're collaborating together and sharing the best of chiropractic and the best of physical therapy. And frankly, I knew when I went into that program, which was in 2018, 2019, there were some holes in my game. I mean, there were some things that I was missing clinically, and I didn't like that one bit. And so I was enthusiastic to go and be part of this program and learn some new stuff, which I bring back to practice as it comes up. And I was also eager to go to this program and share some of the things that I do know. And I like collaboration. It works for me. So anyhow, one of the conversations that we had, now when you go to a program like this, you got to pay attention in class and take notes and study and pass the test. Everybody understands that. That's a given. But the best stuff that happens is the conversation at lunchtime and in between the breaks when you're just networking with colleagues. And like, I adjusted somebody and there's a whole crowd of people staring over my shoulder with this, how did you do that? What was that? I've never seen that before. And that just makes my day, that the chance to share, the chance to teach, and like, that's the stuff that I do every day in practice. I mean, what do you mean you've never seen that before? And so when I was in chiropractic school, and also when I was very very early in my career, I trained with some fantastic. I can't believe how lucky I am to have trained with the mentors that I've had. And I'm certainly not a name dropper when I talk about my patients, but I'm a name dropper when I talk about the people who I've worked with and who I've worked under and where I learned how to do things. And a big chunk of my training comes from a place called the Motion Palpation Institute. And when I told that to this room full of chiropractors and physical therapists, all the chiropractors knew who that was, and all the physical therapists were like, "They won't take us. They will only let chiropractors in their classes. This is the stuff we have to learn." So I felt kind of validated about, well, this is what I do every single day. I mean, I did learn some cool stuff along the way, and I'm able to bring it here for my patients. So that was wonderful. So what exactly is it that I do? Well, I do. It all begins with a conversation to get to know the patient a little bit and what their concerns are and what it is that brings them in to see me and what their expectations are out of our interactions and what it is specifically that I can do to help them, and maybe in some cases what I can't do to help them, and where we can help them find that help. So it begins with a conversation. And then once we've determined that this particular patient and their particular set of challenges is appropriate for what I do hands-on chiropractic adjustments to the spine and to the extremities. That's that quick, high-velocity, short-range thrusting maneuver that occasionally generates a popping noise. I love that noise. I wish I could just walk down the street and give people hand gestures and they would make snap, crackle, pops. It doesn't quite work that way. And frankly, some of the best adjustments are quiet ones, but I love that noise. I also do a little bit of trigger point muscle therapy to get muscles to release, tight muscles to come out of spasm. Now, I know plenty of people who are here and listening in live, and people who are maybe who know us well. and are listening in via Zoom or Facebook or whatever platform we're on right now, remember fondly Adam, and remember Jacob and Herman and even Andrea recently, who've been our muscle therapy people. These people are true trigger point therapists. That's the scope of their practice. That's what they do. I throw a little bit of trigger point therapy into my chiropractic sessions where I deem it to be appropriate in order just to make tight muscles relax to the extent that I can adjust those joints more smoothly. Another technique that I use is called PNF stretching, proprioceptive neurofacilitated stretching. Ooh, big science words. Proprioceptive neurofacilitated stretching. Um, what that means is we're going to use neurological reflexes to enable me to stretch the patient's body a little bit further than the patient's normally capable of stretching. Another one of my favorite techniques is low tech rehab. What is low tech rehab? Let's do some of it now. Let's do some low tech rehab right now. We're going to do a breathing exercise. If you are sitting here, and this is especially for my friends sitting at my 12 o'clock perspective, hi, 12 o'clock. Um, but for everybody out there who's sitting, if you are listening in and not driving or not doing something that needs or requires any kind of precision, attention to detail, if you're just kind of cruising along and paying attention to me, please join us with this. But what we're going to do is we're going to sit as straight and tall with the perfect textbook impress your chiropractor posture. So we're sitting up straight, and we're going to make our abdomen, that's going to be the area from the bottom of our chest to approximately our belt buckle. We're going to make that area as tall as possible. So we're giving ourselves a good stretch here. And at the same time, we're throwing our shoulders back. So we're not going to shrug our shoulders up, but we're just going to throw them back. And we're going to be almost feeling like we're leaning backwards. And like when you go to get yourself measured, when you're at your PCP's office and they measure your height, no matter how tall you are, you want that extra eighth of an inch. Everybody wants to be taller, even if it's impractical. So what do? You stretch your head up as high as you can. Wait, don't forget this, right? So we're going to make ourselves as tall as possible. And what I'd like everybody to do is just kind of freeze themselves in that position. So we're going to inhale as deeply as possible through our noses without shrugging our shoulders up. We're just keeping them sunk backwards. So please, big deep breath in through your nose while in that posture, and you should feel your chest and abdomen. Although you have that length or that height in your abdomen right now, you should feel everything expanding out forward in front of you. And my friend at 12 o'clock is doing such a good job. She's going to hit me with her chest. She's expanded so big. We're going to hold for 1,001, 1,002, and blow out through your mouths. And as you blow out, you're going to feel your abdomen and your chest sinking in, but sinking into that same good posture position that we talked about. Let's do another one. Big deep breath in through your nose. Torso is expanding. Everything is getting bigger. You're still tall. You're sucking in delicious oxygen. We're going to hold again, and blow out through your mouth. All right, for the time being, last one I promise. Big deep breath in through your nose. Big expansion in your torso without compromising your posture. We're getting bigger, 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 bigger. Hold 1,001, 1,002, and let's blow out and relax. Okay, so how's everybody feel? Hopefully, you feel maybe just lighter, a little bit more energized. Maybe your body feels more relaxed. And as we get a little bit further in terms of how the workshop is rolling along, I'll hopefully be able to explain why you feel that way. Now, what I want to first of all encourage everybody to do is that deep breathing exercise. We just did 3 deep breaths. It took us less than a minute, and we did ourselves a world of good, sucking in all that delicious oxygen beyond our normal threshold. That's low tech rehab. Regardless of your injury, we could be talking about somebody who's challenged with headaches. We could be talking about somebody who's challenged by rehabbing a sprained ankle. We could be talking about anything in between. One of the very, very necessary ingredients, arguably the most important ingredient to heal our bodies, is oxygen. We got to get enough oxygen into our blood, circulating its way around through the body in order to heal our injuries and wounds and challenges. So, low tech rehab. We don't rely on a lot of fancy equipment. If you're somebody who habitually goes to the gym and you have a workout program and you enjoy lifting weights and you enjoy going to yoga class and you enjoy going to Pilates and you enjoy Tai Chi and all of that is part of your daily or weekly or whatever routine, I might I might tell you about specific exercises that require specific equipment that I really think you ought to do. But if you're not that person, low tech means what are we doing using our body as the most complicated piece of equipment? Might ask you to use some ice. If you don't have any, I'll give you the recipe. I might ask you to use a shower towel. We'll find you one if you don't have a shower towel at home. That's low tech rehab. Now this is really exciting because I'm a low tech person. Look, some people come out with PowerPoint. I got a sheet of paper here with a few notes and bullet points to make sure that I use the appropriate big words and examples. And I got these little reminders for myself, not a PowerPoint to go by. That's as low tech as I get. I like low tech rehab, but we got some exciting stuff going on here at the World of Wellness Center. And just because it's not my way of doing things doesn't mean it can't become my way of doing things. I'm getting to be one of those old dogs willing to learn some new tricks. But we're doing some high tech rehab here. We've introduced a few new modalities. We have a sauna. We have a dry sauna that we can figure out a way for you to schedule some appointment time to sit in the sauna and detox and expose yourself to some good, warm, hot room stuff. And later in the workshop, I'm going to explain to you exactly why that's important and why that's relevant. We have what are called pneumatic boots. These are like blood pressure cuffs that you would wear as boots that we will inflate to the point where they're going to start to aid circulation. Remember, we got to get oxygen into the body. And once the oxygen is into the body, that means now we have to worry about circulating it a little bit more aggressively and getting it to parts of the body that it normally won't make. For example, the feet. Tricky one. So we have this pneumatic pressure cuffs that will help to aid circulation in the lower extremity from your approximately your hip to approximately your toes. What else do we have? We have an inversion table. Uh, um, Inversion table means that we're going to turn you, if you can stand it, we'll turn you all the way upside down. But more realistically, we'll get you to lie in a position that's a few degrees breaking the plane of horizontal to the ground in order to get some of that circulation to head more towards your skull and less towards the way where gravity would otherwise normal pull it. So we're aiding circulation into this cranial vault. We're also using it as a tool to create spinal traction and spinal flexibility. So these are high tech rehab stuff. No matter how much of a fan you might be, we can't let you take the pneumatic pressure cuff boots home with you. We can help you out with the shower towel, but not necessarily the pneumatic boots. The difference between high tech, low tech stuff. The other thing that I do here, I mentioned low tech rehab, the chiropractic adjusting to the spine and the extremities, mentioned the stretching techniques, I mentioned the trigger point techniques. I do condition specific nutrition. If somebody has a systemic organic nutrient deficiency, I recommend that they come and see one of our nutritionists here, specifically Jeffrey Niznik. And we work with nutritionists who don't necessarily work here at our center, but we refer to them and share patients back and forth. So we got somebody here for you. We got other people we can help you find. But if we're talking about not so much of a systemic organic problem, but we're talking about which nutrients would somebody take in order to reinforce the chiropractic treatments that I'm doing, I help my patients out with that too. Speaking of nutrition, I'm taking a quick drink break to enjoy a healthy mix of my Pro Reds and my Power Fuel. Shameless plug number one. Um, Today's topic is chiropractic, rehab, pain management, and throwing in that low tech exercise and a few show and feel demonstrations. On Wednesday, I'm going to be speaking. I'm going to repeat some of the things that I said today, but I'm going to do a lot more focus on nutrition and a less focus on the rehab type of stuff that we're doing today. So when I tell you the reds and the power fuel, this is what's known as a teaser. I'm talking on Wednesday, and we're going to go into a deeper dive as to why I like this stuff so much in my drink. Okay, so why do I do the treatments that I do? What are my motivations to put my hands on somebody's body and make adjustments and manipulations and to stretch them and to press into their pressure points? Why would I do that? And why would you want to have that done to you? Okay, so my goal for 100% of my patients is pretty much the same. We want to improve their brain body communication. We want to be able to help them increase their ability to breathe deeply. We want to increase or improve their posture. We want them to basically live more comfortably in their bodies, the only true home that they know. Now you'll notice on my checklist of what is it that I do with my patients. I didn't say help them get out of pain. I didn't. We don't chase pain around. Now, pain is a very bizarre measuring stick. You ask a patient, how well are you doing? Well, the reason they came to see me or any chiropractor in the first place is very likely because they have pain or discomfort, or they feel a physical challenge in their bodies where they move uncomfortably and more ratchet like, and they want to move more like they've been lubricated. Maybe they have headaches, maybe they have lower back pain, maybe they have a pain that originates in one part of the body and travels down through an arm or through a leg and creates a tingling sensation or a burning sensation somewhere else. That's real. That is 100% real, and that's the sort of thing that I hear from almost all my patients when we just begin our conversation. What brought you in, and what can I do to help you? Well, I have this pain. Now the reason why pain is such a poor indicator or a poor guideline of what it is we're going to do is because everybody has a different pain threshold. If we had a hypothetical meter where I could put your palm down on this meter and it measures on a scale of 1 to 100 how much pain are you in? Well, we're going to have two people with identical conditions, and one is going to register a 75 and the other is going to register an 18 because they have completely different pain thresholds. So, my assumption, and not just my assumption, but the assumption of my mentors. I mean, I told you about the Motion Palpation Institute and how lucky I was to stumble around that group. And, I got to be, when we were in that PSP, that primary spinal practitioner program, I was the chiropractor adjusting other chiropractors and other physical therapists in front of other chiropractors and other physical therapists. I mean, you can't fake those people out. They know the industry. They know when they've been adjusted. And they're like, "Hey, Orbach, can you do this? Can you show me how to do that? Can you?" Well, of course, we're all here to learn. The information is here to filter upwards, not to be held a secret. So those treatments from the Motion Palpation Institute, my mentors there, Mark King, Terry Elder, Randy Carlson, uh, um, my mentor in neurology, Ted Carrick, and more significantly, Ken Erickson, the people who taught me how to do extremity adjusting, Mark Charette. I mean, these people are geniuses in the chiropractic profession. Like, my heroes are not going to appear on postage stamps. My chiropractors don't get to that level. But Mark Charette was awarded. He didn't ask for it. He didn't apply for it. He went to go teach a workshop in Australia, and he was granted a license to practice in Australia. Now, I don't know why anybody would want to do this, but if you want to immigrate to Australia and just move there, do you understand what a complicated system of paperwork and nuts and bolts and red tape and hoops you have to jump through and navigate your way? It all becomes obsolete if you have a professional license to practice there. They loved him so much in what he did that the chiropractic profession of Australia gave him red tape to walk in and have citizenship, or at least residency and a working. So that should tell you how profound some of these people are. And they'll tell you this is what they taught me. We don't chase pain around. We're not here to we're not here to the patient says I hurt right here. We don't apply our treatment right here. We look at people from head to toe and we look at people systemically and we look at, well, what are all the influences? What are all the possible things that can cause the pain right here? And what we learn is what's causing the pain right here is probably a cascade of neurological events that we want to disrupt and change. You guys cool with that? Think about this for a second. Um, During the Civil War, soldiers were injured in battle to the point where they're taken to the medical tent, and the only thing that can be done for them is to amputate their leg or their arm. So they're fed just enough alcohol to withstand this, and they get battlefield amputation. Then, years later, those same soldiers are telling you, I feel pain in a leg that no longer exists. Let's take a second to think about that. This leg was chopped off because I got a shrapnel from a bullet wound lodged in it. It started to get infected. There was nothing anybody could do to save it. So the only answer to save my life was to amputate the leg. Sounds plausible, right? You can nod your heads. 12 o'clock. Sounds plausible. 2:30, 3 o'clock, 12 o'clock, 2:30, 3 o'clock ish. Sounds plausible. Yeah. Now, all right. So the person, like I refer to people by where they sit facing me on the clock, and I got somebody who's very eager to interact with me sitting at 12 o'clock. So that's what I'm referring to her as. And I have somebody here at 2:30 that I'm just checking time and temperature. We're good. And I'm talking about Civil War injuries, and she says I saw Gone with the Wind. As far as I'm concerned, that is the retort of the day. You like if there was a prize, you win. Anyhow, so here we are with this Civil War soldier who's had their leg amputated, and yet they feel pain in a leg that's no longer there. Now, if you want to refer to that as phantom pain, that's fine. If you want to refer to that as Sudex atrophy, that's fine. If you want to refer to that as reflexive sympathetic dystrophy, that's fine. All that'll work. But now we got to do a little deeper dive and say, why? Well, we're going to say that pain is a neurological phenomenon. So if we're going to make that a brain-based neurological phenomenon, so if we're going to make that leap, then well, what about the pain I feel in my shoulder, which is clearly present and not amputated, and I tend to keep it that way, but there's no denying that it hurts. Is the problem my shoulder? Is the problem in my brain? Is the problem the communication network between my shoulder and my brain? Is the problem that my brain is not getting enough stimulation from my hip or from my ankle, and the brain is shutting down a little bit, which amplifies the brain's ability to feel the pain in my shoulder? I don't know, but that's what we're here to find out because the answer is different for different patients. So let's say like this. Let's say I take a string of dental floss and I tie a knot in it and I put it between my bottom two front teeth. And my friend at 12 o'clock, who's sitting opposite me, grabs the other end of the dental floss and she gives me a hard, sustained pull. I'm going to have a friction rub at my gum. It's going to bleed and it's going to hurt. Pretty straightforward, right? But my real problems are going to be here at the hinge of my jaw because as you pull with that dental floss, the lower aspect of my jaw is going to come forward with you, right? We're playing tug of war now. And these muscles here up by my temples and up by the hinge of my jaw are playing tug of war against you. Now, those muscles are really, really strong to chew, but I'm recruiting them to do something that they can do, but not something that they're designed to do, which is pull my jaw backwards. So they're going to fatigue pretty quickly. They're going to spasm, they're going to tighten, and then they're going to really hurt. And that's going to impact my ability to open and close my mouth, my ability to chew, my ability to talk, and so forth. So if we're going to fix this problem, we got to do three things. First of all, we got to get rid of all the inflammation that builds up around the hinge of my jaw. And probably in a lot of other places because this is a systemic event. And that's something we're going to talk about in detail on Wednesday. In the meantime, I want you to think about how much Dr. Orbach really likes turmeric and fish oil. We got to repair the mechanics of the hinge of the jaw. We got to get these muscles to relax. And then we got to coax the jaw in its proper direction to get it unstuck so that I can open and close through normal ranges of motion and chew and enjoy my delicious Middle Eastern barbecue grilled food later. That's what's known as a shameless plug for Mr. Z. We have great food here today. The third thing that has to happen is Miss 12 o'clock, please stop pulling on the dental floss. Otherwise, we do the same thing over and over again, correct? So, muscles, tendons, and the skeleton behave the exact same way. Muscles or a group of muscles or an action of muscles are going to spasm. Why? I don't know. Maybe they were overused. Maybe they were underused. Maybe they were fallen upon. Maybe they're nutrient deficient. Maybe it's a perfect storm. Muscles spasm, tighten, pull in the wrong direction for us. All of those muscles attached to tendons. The tendons are a lot like the dental floss. They're a fixed length. No matter how hard you pull on the tendon, no matter how hard you pull on the dental floss, it's not going to stretch. It'll inflame. Dental floss won't inflame, the tendon will, but it won't stretch. The other end of the tendon attaches to the skeleton, to a bone, or really, really close to where two bones come together, and that's called a joint. And that's where we have movement. So we got to get tight muscles to relax. We got to use that neurological stretching technique to get the tendons to come out of spasm and activate. We can't stretch them, but we can activate them. And we got to get chiropractic adjustments to get that skeleton or those joints to maneuver or to mobilize in the directions that they've been frozen in or stuck in or challenged in. Everybody good so far? Now, I'm sitting here doing my presentation, talking about the things that I enjoy talking about the most, having a good time with my small but active and lovable audience. And I've neglected to mention somebody very important. Over to my right, I have IT savant Phil. He's not in the picture here, but he's monitoring the game plan. So, are there any questions from the crowd at large? I'm good to go. I can keep rolling. Good. All right. So, we have this dental floss scenario going on in our bodies. Tight spasm muscles, overexertion, tightness, yanking, pulling, torquing tendons, restricting movement at joints. So, now here's the part that I think is really super exciting. This is the part that I bet my career on. Now, what goes on at the joint? Obviously, there's movement. Obviously, movement occurs at the joint, but there's a lot of neurological tissue that lives inside of joint spaces. Neurological tissue called receptors, more specifically, mechanoreceptors, type 1 and type 2 mechanoreceptors. A receptor receives and transmits information. So a mechanoreceptor is, if nothing else, movement and pressure sensitive. So as I maneuver my elbow through space, I think I have pretty good range of motion here. I can swing this hammer until my arm fatigues. I got good range of motion. So what's going on is the pressure sensitive mechanoreceptors are sending information into my nervous system through the peripheral nerves into the spinal cord and up to the brain to say, we are in motion. Okay? We're moving. So the brain is now going to position my body in space in the most advantageous way possible. Okay? The number one output, the most neurological output that your brain is doing all day long is keeping your eye, well, maybe not all day long because it disqualifies when you sleep with your eyes shut. What we're doing is we're keeping our eyes level with the horizon. So if our eyes are level with the horizon, we should be able to orient our body in space pretty well to stay out of danger. Now, I illustrated for you this elbow movement But what would happen if I stood closer to the microphone and I did the same elbow movement and I hit my hand on the table here and then I came up and knocked the microphone over? Well, that would be pretty bad. That would not a life and death emergency, but at some point, don't you think I would hit my fist on the table enough times that it would start to hurt? Don't you think that knocking the microphone over would really disrupt the presentation? Don't you think all of you would say, I certainly want to see a better coordinated chiropractor than that guy? I mean, come on. So my brain is going to keep my eyes level with the horizon, and the brain is going to influence, it's going to take influence from where this arm is in space and what it takes to keep my eyes level with the horizon, and a number of different other mechanisms, such as how the fluid in my ears is moving, such as the fact that there doesn't appear to be any danger coming from my left. If there were a saber-toothed tiger sitting on the floor over there with a chain that would allow it to come this close to me, my brain would say, "Don't take a step in that tiger's direction and hit your arm on the desk. Stay where you are." That's called proprioception. Your ability to orient your body in space, the ability to position your body in a way for the best possible advantage for survival. You guys cool with that? Makes sense? Questions, comments, moral outrages? Not even from the crowd yet. Not even from the virtual crowd yet. So here I am. You might say, dude, don't you get tired of that? You just keep pumping your elbow up and down. I mean, at some point, your biceps are going to fatigue. Yeah, that's true. But what I'm also doing is that movement, the pressure sensitive joint mechanoreceptors, the type 1, 2, and 3 mechanoreceptors that live in this joint are telling my brain, amongst many other things, what do we have to do to keep your eyes level with the horizon? So far, so good? All right. Now we have a second type of mechanoreceptor called a nociceptor. Now, what these now one thing I should tell you, I brushed over a very important point. At some point, this should fatigue. At some point, my arm is just going to be way too tired to continue this movement. You guys on board with that? Now, I'm a pretty strong guy. I can probably do this longer than most people, but it's finite. I'll fatigue. I'll get there. So when that fatigues, what happens? The mechanoreceptors that indicate position in space, groups 1, 2, and 3 from type 1, they fatigue, they're finite, they are deactivated. We got to do something to get them to fire again. Okay? We got to wake them back up. You guys good with that? Now, the next type of mechanoreceptors are called nociceptors. Noci is from the Latin of harm. So the nociceptors are going to send different information. They live in all the same places, in joints, primarily in joints, but also in tendons, also in muscles. Remember, my chiropractic technique includes work on muscles and tendons as well. Okay? So these nociceptors are going to tell the brain, danger, Will Robinson, danger. We have an indication of harm. We have an indication of injury. So bad stuff, incoming bad stuff. Now, here's the thing about nociceptors. They don't fatigue. Once they're on, they are just on. Okay? So these nociceptors travel the same pathway as the type 1 mechanoreceptors. What the nociceptors are going to do is they're going to travel through those same peripheral nerves up the spinal cord, into and up the spinal cord, and their first stop is going to be the brainstem. Brainstem should be implicated into survival stuff, like basic stuff, like breathing, heart rate, blood pressure, elevation of cortisol. You guys know what cortisol is? It's a hormone that elevates in times of stress. People have elevated cortisol, they start to go into sympathetic nervous system fight or flight mode. Good luck getting somebody with elevated cortisol to just calm down and relax. And you guys ready for a cliffhanger, a teaser? On Wednesday, when I review some of these concepts and substitute out the rehab and put in more nutrition, we're going to talk about suppressing cortisol. So the cortisol level increases, the heart rate has increased, the blood pressure has increased, and we have the ability to breathe has decreased. So now we're not breathing deeply from our diaphragm muscle. we're breathing from these muscles at the front of our neck, and we're using this as a pulley system to yank our rib cages up in the air to suck in the bare minimum of oxygen to keep ourselves going. What that's all called is autonomic concomitance. So far, so good? So far, so good. Okay, so now our nociceptors have dumped some bad news on our brainstem, and now they're going to continue their journey to an area called the somatosensory cortex. What's the somatosensory cortex? It's part of the brain. Somato means body. Sensory, you guys know what sensory is. Your eyes, visual light, stimulus, there's a sense. I feel the hard wood of the table, there's a sense. So we sense the environment around us. Cortex, that's where we think. That's where rational thought occurs. So let me ask you guys a thought question. We can kick it around if you like. If you've ever had the experience of being in pain, or maybe if you know somebody who's ever being in pain, were they really thinking at their top flight, top notch, total rational self? Or were they just kind of agitated and just saying whatever? Sir, you dropped look at Dr. Orbach surveying the crowd and realizing what's going on and just picking stuff out of space. Anyhow, uh, um, have they really been at their most rational, calm self, or are they anxious and wound up and like saying, just blurting stuff out? Those are characteristics of people who are in real, true pain. So, like I said in the midpoint of our conversation here, like I'm looking at indicators. I mean, why does the shoulder hurt? Well, anything that causes shoulder pain might have been stimulated, or anything that prevents shoulder pain might have been turned off. Guys, wrap your minds around that for a second. Maybe because of the presence of nociceptors throughout our whole bodies, we're actually designed to be in pain all the time, but we have mechanisms in place that just calm them down and shut them down, and we don't experience pain all the time because we have a system of checks and balances. But there's a failure of this checks and balances system, and now my shoulder's in pain, right? We can't chase that pain around. We have to figure out where in the checks and balance system. What are we going to do to stimulate the brain so that we stop feeling phantom pain in a place that doesn't exist, so we don't stop feeling real pain in a place that does? You guys on board with this still? You guys buying what I'm good? And IT savant Phil, the internet world is cool with me too. Okay, good. So you know what I want to do now? I want to do some low tech rehab. Let's all do a little bit more of that deep breathing exercise. So I'd like to have everybody, once again, we're going to sit up as straight and tall as humanly possible. We're going to let our shoulders sink backwards. We're going to lengthen our abdomen so we're almost leaning back without leaning back. And we're going to take a deep breath in through our nose. I'm going to feel our whole torso expand, expand, expand. And we're going to hold that deep breath for a moment in time. And let's blow it all out through our mouths. Again, big deep breath in through your nose. Excellent. Hold it. Hold it a little bit more. Hold it again. And blow out through your mouths. One last time. Big deep breath in through your nose. Everything is expanding. Holding. Hold some more. And blow out through your mouths. All right. Once again, let's jump back to something I said a few minutes ago. We talked about that autonomic concomitance. We talked about that sympathetic nervous system escape from the brainstem where the nociceptors activated it. Teaser alert, on Wednesday, we're going to talk about what you can do nutritionally to help suppress those problems. But right now, sometimes it's not what you take, it's what you do. The influx of more oxygen than you are normally used to having, your body survives on a certain amount of oxygen. It's just what you're used to. Michael Endurian, who was a Tour de France winner. I think he was previous to Lance Armstrong, but anyway, he won the Tour de France, and that's a very, very competitive and very challenging endurance athlete effect. And so scientists and physiologists were very eager to study Michael Endurian, and what they found out is that he breathed 8 times in a minute when he was relaxed. Now, when I examine a new patient, if I'm counting their respiration rate, I see somebody breathing around 16 to 18 times a minute. I'm thinking like, wow, this person is good. This dude was breathing 8, right? So let's logic this out and follow it through to its natural destination. And when we talk about the importance of what can I do, like if there is just one take home that I can force feed you today. Look, I encourage you all to go get some food with Z, but I'm not force feeding you that. I am force feeding you delicious oxygen. If there is one thing that I really want to impress upon you is how important deep breathing is for systemic well breathing, systemic well being. So what a choice of words! I said systemic well breathing. I'm putting that on a bumper sticker or a T-shirt. But if you take a minute to 2 minutes at a time, at least 5 times a day, and you do the deep breathing that we're talking about, the things that we've illustrated and demonstrated and had show and feel with just now. Look, I can't promise you big things. I can't promise you massive switches and massive changes in your life. But I can promise you that however you feel now, you'll feel better if you start doing that. So far, so good? You are absolutely correct. You are okay. The woman, my friend at 2:30, who said I saw Gone with the Wind, might have outdone herself. Her doctor told her that deep breathing exercise will bring her blood pressure right down. Now, just a little bit a while ago, we talked about that blood pressure elevating when the brain stem is being bombarded with nociceptive input, right? So now we're going to have sympathetic nervous system. Our nervous system can be subdivided into two categories for the purpose of our conversation. Category number one is going to be voluntary stuff. If I say wave goodbye, you all understand the language. You can do that if you want. If I say dilate your pupils, now a little bit more complicated. That's not voluntary stuff. We need some external stimulus. What if I take a high powered flashlight and shine it in your face and remove the flashlight and here's the beam and remove it? We might see your pupils dilate then, but that's what it would take, right? So in that non-voluntary nervous system scope, we have two categories. We have the parasympathetics and the sympathetics. The parasympathetics are wine and dine and our relaxation and rest and digest, and our sympathetics are wound up. That brainstem, man, did it get a lot of nociceptive input, and now we're sympathetic dominant. Our blood pressure has escaped. Our breathing has gone down. Our heart rate has gone up. Our digestion has gone down. Blood pools to our extremities, not in our torso. We've become more and more acidic. Probably for the most part, an undesirable state. Would you agree with me? One of several ways to shift out of sympathetic dominance and let's move to parasympathetic dominance is we got to suppress the sympathetic nervous system. So what does that? Our cerebellum, it's a different area in the back of our brain. The cerebellum will inhibit the sympathetic nervous system. So if we inhibit this, we allow this to come back up. True story. It makes sense, right? So when we think about, well, what's the cerebellum respond to? Two things in particular. One are balance. The better we keep our eyes level with the horizon, the better our balance, the better our cerebellum is going to do. What else does our cerebellum respond to? Oxygen. The more we breathe, the more deep breathing we do, the better we breathe, the more this is able to happen, the more our cerebellum activates. The more our cerebellum activates, the more we suppress the sympathetic nervous system, the more we allow our parasympathetic nervous system to come up, the better our blood pressure becomes. That's a little bit longer version of the explanation that I'm sure your doctor gave you, but whoever told you deep breathing will help you suppress your blood pressure was spot on. Um, we're doing some name dropping, and we're going to give a shameless plug out for somebody, Franny Perez, who is a medical doctor who does not practice like a conventional mainstream medical doctor. So, well, she's still brilliant and deserves a shout out. So, anyhow, um, we talk about this change in sympathetic parasympathetic dominance. And the other statement was the conventional medical doctor is not going to tell you all of that. I don't know who knows what. I mean, I'm not going to climb into somebody else's brain and figure out what they know and what they don't know. And like I took a lot more neurophysiology classes than anybody really ought to, and now I'm just a little bit dangerous because of it. But all those medical doctors, they took neurophysiology when they were in school. They did a rotation through the neurology department. They should know that oxygen suppresses blood pressure, whether or not they know the mechanisms involved and whether or not they can explain it. Some can, some can't. Depends what they're interested in, but they're probably not going to take the time to tell you that. And that's actually something that I'm proud of the way we do things here. We take our time with people. We do lengthy chiropractic appointments. If you have questions, we take our time and answer them. We're not we're not in a rush. We're patient centric. I mean, when you get to come to a workshop that we do here, like to me, it's an absolute requirement. Like I can't do a workshop without making sure that there's at least some take home that I can explain this to you on Monday morning, and by Monday afternoon you can be doing something or understanding something that you got out of this workshop. And I feel like the deep breathing exercises, that hits for me, that works for me. But if I come up here and do a presentation and I don't give everybody something that they can't benefit, I feel like I failed. I absolutely failed. So I feel like this is a success today if you guys grasp the deep breathing. But anyhow, I do. I'm before I run out of time, I want to make sure that I illustrate a couple more points that are relevant to what we're doing. So anyhow, we're talking about stimulating the cerebellum with delicious oxygen to inhibit sympathetic nervous system, to expand parasympathetic nervous system. So what else? What else? How can we inhibit these nociceptive bombardment? These are the type 2 mechanoreceptors that say harm is happening, and they're activated by tissue destruction. I, I did this so many times that the pressure sensitive good mechanoreceptors, the fast adapting ones fatigued, the slow adapting ones fatigued. The only ones that are still firing are the nociceptors. Okay, we got to somehow inhibit these nociceptors. They respond to tissue destruction. They activate. Activate's a better word. They activate with tissue destruction. They activate with disadvantageous pH. Uh, um, they activate with too much or too little pressure. Um, they 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 activate due to cell membrane failure. They activate due to free radical metabolical debris that we clean up with antioxidants building up. So these nociceptors, and once they start firing, they fire until they continue to fire, but we have to get those type ones to fire to suppress them. Are you good with that? Everybody cool with that concept? So remember, the type 1 mechanoreceptors, they live primarily in joints. So here's the concept I'm betting my career on. When we do chiropractic adjustments to mobilize joints, to adjust joints, not because somebody's back is out of place, not because somebody's talus is out of place, but because those joints aren't moving the way they're supposed to, just as my elbow will cease to move the way it's supposed to when it's fatigued. When we do those stimulations, we're activating the first type of joint mechanoreceptors, which fire to inhibit the nociceptors. So we can't shut the nociceptors off, but we can certainly block them. And when we get good chiropractic adjustments to the skeleton, that's a very critical, very essential part of the nociceptive inhibition protocol. So far, so good. Where else do type 1 mechanoreceptors live? In muscles. Why do you think it's so important to do a little bit of trigger point therapy in conjunction with chiropractic adjustments? Where else do the type 1 mechanoreceptors live? in tendons. Remember, tendons connect muscle to bone. Why do you think it's so important to do that neurological base, that proprioceptive neurofacilitative stretching in conjunction with chiropractic treatments, chiropractic adjustments? We have to address the muscle, we have to address the tendon, and we have to address the joint in order to get the mechanoreceptor pools to fire efficiently. Now, remember, I have pain in my shoulder. There's something in the communication network between my shoulder and my brain where I have too many nociceptors firing and not enough type 1 mechanoreceptors firing to suppress them. Can you guys picture all that? A little bit? A lot? Want me to explain that again? Shake your heads, nod your heads. 12 o'clock, you okay? All right. So I got a problem in my shoulder. Now, what we're going to do is we're going to start to fire off those type 1 mechanoreceptors, but it might not be enough to suppress all this nociceptive communication. So I had a great idea. Yeah, fantastic idea. Let's take some type 1 mechanoreceptors from other parts of the body that may not necessarily be my shoulder. They may not necessarily even be involved with my shoulder, and let's fire them off too. So we're going to use type 1 mechanoreceptors from all over the body in order to suppress a more focused nociceptive population. That's why I like to treat my patients from head to toe. That's why we sit there and have a conversation. The patient says to me, "Man," I said, "What brought you in?" So I have this killer pain in my shoulder. Uh-huh. Well, let's drill down on it and see, well, what was the genesis of that pain? How did it originate? Did you fall? Did you have an accident? Did you have a traumatic injury? Do you eat McDonald's 4 times a week? Do you, right? And when I'm asking all of these questions, I'm trying to determine two things. One, are there any red flags? Is this shoulder pain a symptom of a life and death miserable experience that, let's be honest, there's certain conditions that you really do have to see your medical doctor for, not your chiropractor? And I'm like, can we narrow this down? Oh, good, no red flags. Now, my next round of questioning is, I'm trying to determine how many places in your body your nociceptive activation system is coming from, besides just your shoulder, and what kind of type 1, like how much work are we going to do on your ankles and knees and your lower back in order to create enough stimulus to inhibit pain in your shoulder. So I favor chiropractic treatments that are total body treatments, certainly not limited to areas that hurt, and certainly not limited to the spine and the spine only. That's the stuff that I learned with my experiences with the Motion Palpation Institute as a Mark King, Terry Elder, Randy Carlson, as a chiropractic student, and early in my career. I'm a little more than 21 years into this. I'm 109 years old, but I take good vitamins and minerals. And we're going to teaser alert. We're going to talk about that more on Wednesday. That's the stuff that I learned working with General Systems Neuroscience with Ken Erickson. Man, what a mega genius he is. And Ted Carrick. I mean, I don't know if that name rings a bell for any of you, but when Sidney Crosby was having his concussion issues in 2009-ish, and the Crosby family hired a chiropractic consultant, and the UPMC neurologists all went batshit crazy over that. That chiropractic neurologist was Ted Carrick. I had a brief stretch studying with him. He was a mentor of mine. Mark Charette, he can go to Australia anytime he wants. These are the people who teach head to toe chiropractic. These are the people who teach systemic treatment for systemic problem with local manifestation. These are people who I'm very proud to have studied under. And this is what I bring to my practice every day. And I have a few mentees who are out there circulating, not necessarily here, but out in the world. And I'm hopeful, I'm very hopeful that they're doing the things that I taught them, that I learned from my people. I can't go to anybody's practice, look over their shoulder, and make demands as to what they do. But I'm certainly optimistic that there's a small, little upcoming new generation of chiropractors who look at these problems the same way I do. So I want to, first of all, if there are any questions, comments, yes, please. I do. Well, okay. This is really a good. I mean, maybe I left an ambiguity. Thank you. The question was, I talked about muscles and tendons, but not bones. When I talk about joints, I mean, do you feel like I've covered joints? We talked. Okay, okay. So when I say joints, a joint is where two bones come together. So where we have movement here at the hinge of where my radius and my ulna and my humerus all interact, three bones interacting at the elbow. They all come together and form a joint. So if I left any ambiguities, I humbly apologize. And Mhm. Mhm. Oh, okay. All right. So the question or the comment was, the patient has heard, my friend at 2:30 has heard that there's no such thing as bone on bone, but in looking at the X-ray, then it appears that the cushioning is all worn out. Is that okay? Okay. Okay. So if you if you walked in here under your own power, if one was wheeled in on a wheelchair, I'm going to go back on what I'm saying. If somebody walked in under their own power, I feel pretty confident in telling them they don't have bone on bone arthritis. Now, when you look at an X-ray, it's a radiologist, somebody who reads X-rays and internal imaging. That's a career unto itself. That's a medical specialty that involves a lot of training. And one of the things that you look at when you see these X-rays are shadows. So a really good radiologist knows where the shadows are, what shadow, what's worn away. And there's no debate. Like some people, everybody actually, you give them long enough, they're going to wear away joints. I mean, that's gray hair for the skeleton, normal living. When those shadows start to appear, a good radiologist will know what a shadow is and say, now there's a sliver of space. That's why this person walks in under their own power. In orthopedists, they're doing sales. They're doing some sales work. A chiropractor is doing some sales. Maybe he doesn't have the ability to treat you. And instead of saying, I'm sorry, I can't help you, says, I'm sorry, but your problem is severe. Go see somebody else. I mean, that's a possibility. Okay. So I want to thank all of you for your very kind attention, for indulging me. Specific shout outs for my friend at 12 o'clock and my friend at 2:30 who have been active participants. And I look forward to filling in the gaps on Wednesday. Same time, 11 o'clock. Yeah.